do clear lens extraction, if it's a young traumatic macular hole, I'll just go for vitrectomy. It's only if the patient is older, like 50 or 60-year older, in which there is a cataract already some extent present, you don't want to accelerate, then I would go for phaco-vitrectomy. But if young patient with macular hole, I'll just do vitrectomy. So similarly in intraocular foreign body, I try not to do anything to the lens, but absolutely if the foreign body is too massive, you think that it's going to cause damage to the lens, or you want to remove it through the posterior capsule, bring to the corneal wound, then yes, you can do it.
Amit, with you using 27 gauge, when we are doing thick membranes, especially in advanced diabetic eye disease, sometimes I reduce the cut rate and increase the section and also that. How do you find it in 27 gauge when you're cutting the membranes? Don't they get blocked, or do you think they are as good as 23 or 25 gauge?
I think surprisingly it doesn't get blocked. The case you have seen, it's quite a thick one, but its important thing is the suction should be maximum and your cut should be, because you don't want, if your cut would be layered, then it may occlude it. So you cut it into bits, so 10,000 cutter or 20,000 cutter, that will be amazing and that will help in that case.
The same gauge?
I use 25 gauge trocar when I'm injecting, but yes, you can do. So there are accessories available that you can do it with that. But I just put at the end 25 gauge there. Okay, thank you.
Thank you, Doctor. Okay, next talk is my own. I have just intruded into this session. My talk was yesterday, but I got this window because Dr. Qasim couldn't come. Suprachoroidal triumph. Good afternoon, ladies and gentlemen. This actually was a presentation meant for the conference which we were supposed to have in April, May, so the thing of the appointment are still CMS Bhalpur. Anyway, I'll talk about the important subject of suprachoroidal injections, its space, its physiology. We had a very good panel discussion just half an hour back, and this is now the talk of the town. Everyone must be able to do this, and we are all initially, a bit hesitant using this suprachoroidal injection. So briefly, it's a big talk, but I'm going to cut down. I'm just going to summarize what is the anatomy. It's just a space between the sclera and the choroid. This is the potential space. And what we do while we inject anything inside this space, we are atraumatically separating this true space. So we are not creating something special. This space already exists. And the mechanics, the sclera being more rigid than the choroid, it opens up automatically. Then the pressure gradient itself directs the fluid to go back and not in front, because in front, the scleral spur, it adheres strongly to all the layers. So it cannot come in the anterior segment. So the scleral thickness itself, at around 3 to 4 millimeter, the sclera is the thinnest. So once we are approaching this site for the suprachoroidal route, you will see that it is much better than going through the other quadrants. Second, the supratemporal quadrant itself is the thinnest among all the quadrants. And it's written on the slide, the thicknesses and all that, no need to go for that. So physiological space, and this space is meant basically for your uveoscleral outflow, which is important once we are discussing glaucomas. So on the slide, you can see, can I have the pointer? Or you can use this? No. Kidhar hai? Basic anatomy. And this is the area which we are focusing on. And this space, the targeted space, as I just mentioned, the drug delivery route will be targeted to the posterior segment where it is desired. This is already discussed. I'm rushing through the slide because this is a bit long, and General Mother and Professor Moina waiting for their own talks. So these are the various routes which can be used for the drug delivery inside the eye. And we are going to concentrate on the suprachoroidal route. So whichever needle you either make or you get tailor-made, it is not commercially available, it's not very expensive, but I'll be discussing how you make it inside your own OR. It's very simple. I'll be showing you all the steps. So we go perpendicularly around 4 millimeter behind the limbus, preferably in the supratemporal region. And once the tip has gone in, remember the tip is from 0.9 to 1.1 millimeter. It will enter the suprachoroidal space. If it is shorter, this sclera will not allow it to, the injection to go in. And in fact, the patient will have a bit of pain. So if the patient is experiencing pain, it means you're not in the right plane. Depress the needle more. You cannot go inside. Even if you go inside, remember, you are in the pars plana. It doesn't make any difference. At the most, what can happen is you'll go into a speculum, normal insulin syringe, 30 gauge. And this is what I'm showing you in these slides. This is what I'm doing. You just take a granula, the one which fits tightly onto your insulin syringe. I go for around 24. If it is not available, take the butterfly, 24 gauge butterfly. Now, once you have measured how much you have to cut, remember, reverse the end. You need the one which has the bevel end to be at the leading edge. This is what I will show you. See, I put it in, measure it, cut the end. I'm cutting it to see how much tip is out under the microscope. See, this is the part. This is what you want, 0.1 mm. If you are not right in the first go, remove it, make another one. Now the important thing is, see the end. This is the beveled end of that granula. Don't put the cut end in front, because then the gasket effect will not be very effective, and it may even cause a bit of pain. Measured again. Now once you are filling it with triamcinolone, remember it's a suspension. Now you don't have the option of putting this tip in and withdrawing it. So you withdraw the plunger of your insulin syringe, take the triamcinolone after you have rolled it, it has now become suspension, take it, put it inside the syringe. This is what I'm doing now. Hold it upright for a few seconds so the suspension sediments down. Then take the plunger up till it becomes 0.1 ml. Now this is ready for injection. Now you just do it like you do, go for intravitreal injection, and then you put it, depress it, and then inject. Another way to reduce the pain, take the cotton tip like these Q-tips and soak it with alkane. Where the site of injection is, put it on that site and depress it for, let's say, 30 seconds. You know what it will do is, it will reduce the intraocular pressure, and it will give a bolus dose of alkane to that site of injection. So that will further reduce the pain. So many trials are there, because I have a very small study which I will show you in the end. These are the gold standard studies which I was discussing in my panel discussion over there. What to give, when to give, how many you can give. So they say you can repeat these injections after 12 weeks. And the effectiveness of this suprachoroidal triamcinolone lasts up to 6 to 8 months. But if you want to repeat, you can repeat after 12 weeks. So our setup was very small where I was working, and we were only 2 consultants over there. We had we had 1 trainee, but he had already left. So we were busy with our setup, and we were trying to conduct this as well. So the number of patients which we enrolled was over 37, and I will show you which were there. So we had a lot of categories, because the subject was refractive macular edema, not diabetes macular edema. So we had this one, resistant macular edema, both due to diabetes. The maximum cases were for diabetes. Then we studied cases of uveitis, those who were not responsive to the normal treatment. For diabetes, we selected those who had 3 injections of bevacizumab, and they were not responding. Then we shifted them to this, and I'll show you the results. So 37, so you see here, diabetes, maximum patients were for diabetic macular edema. We had 6 cases of uveitis, 2 cases of retinitis pigmentosa, central vein occlusion, and choroidal neovascularization. So we were just experimenting with all the conditions. Whichever case we were enrolling, we were entering to just see what effectiveness this injection would be. So these were the 3 criteria which we were following: vision, macular thickness on OCT, and intraocular pressure, and of course pain, which is not mentioned here. So these were the statistics which came out after 8 weeks of follow-up. As you can see, this is logMAR, remember. So the vision has improved after 8 weeks, after single injection of triamcinolone. This is the mean thickness, which we measured on OCT. It has also come down. And the only problem was intraocular pressure, which went up in uveitis patient. So be careful, if you are selecting patients of uveitis, be careful, don't select those patients who are already on anti-glaucoma, because the pressure will go up. This is at least what our study showed, and internationally, some studies say it doesn't go up. 2 studies I found that they show it does go up. Pain, this is, for most of us, this is our apprehension. Look, we are going to inject, the patient will have pain. The pain is there even in those patients, but it is not that much that the patient will, create hue and cry. But once we ask, did you feel pain? The answer came out, yes, in 43%. So these were our patients, just to show you, these were the patients of uveitis, as you can see. And it became all right. The macula became dry. See here, starting here. And these were the cases who were resistant to all of the treatment. So it did work. For diabetes, as you can see here, top slide, center slide, dried up. We are not concerned, I will not tell you whether the vision improved in these patients or not, because if the ISOS is gone, you may have a pristine OCT, but the vision is still there as it was before, prior to injection. This was another case. So we do recommend, please, as we were discussing in the expert panel, we need multi-center, placebo-controlled, double-blind study as it is recommended internationally. Till now, there is no international published study which shows multi-center study done on suprachoroidal triamcinolone. Avoid in patients of uveitis, as I just mentioned. And is it going forward? What happening? What is happening? Thank you very much. Now I will invite General Mazhar. No, sir, you will come, sir. Sir, General Mazhar is going to talk on the latest trends in premium ions. Sir, he requested that his talk. I think he's still preparing.
मोइन नाराज ना हो जाए ना, मेहमान लाहौर से आया होगा, मेरा लोकल फौजियों ने मिलके इस्टेब्लिशमेंट ने कुछ और कर दिया. अच्छा, मैं भी बेसिकली लोकम का ये जॉब दे रहा हूँ, क्योंकि बेसिकली इट वाज शरीफ अशवानी वाज सपोज्ड टू कम एंड गिव, और मुझे एज यूजुअल चेयरमैन ऑर्गेनाइजिंग कमेटी, हमारा जो चेयरमैन है वो शहजाद है, हर चीज़ का उसने एकदम कल ऑर्डर पास किया कि इख्तियार करके अभी फटाफट बना. इफ़ यू फील समथिंग ऑड अबाउट दिस, डोंट माइंड. तो ये इट्स and I just prepared it now, and this is what I just had in my mind. I will start off the point scenario आपको देता हूँ. A young man, 32 years old, with a vision of 6.75, with a -10 diopter, with 2 diopter, astigmatism at 170 degree in both eyes, was offered refractive lens exchange in both eyes as he was unfit for refractive surgery due to very thin corneas of just 494 microns. एक ये scenario है. And what will you do? दूसरा scenario, when an old man, 63 years of age, known diabetic for last 14 years and on oral hypoglycemic agent with HbA1c of 10, presents with grade 3 nuclear sclerosis and wants to have spectacle-free visions at all distance. And what should be my answer and how will I proceed? And this is what my whole lecture will be in next 15 minutes. And as you must have known that when we are talking about premium IOL, so it has to be, should I think about premium IOL or not? And how will I go about in both these cases? This is my next course of it. Whenever I say premium IOL, they think, what is it? It is what we are going to do, we want spherical refraction we control, whether it's myopia or hypermetropia, we want to control the astigmatism. And as in my the case, the second scenario, also the presbyopia should be controlled. And we also know that it can potentially has the ability to control astigmatism and because of remember that at the moment there are more than 100 multifocal or bifocal or trifocal premium IOLs available in the market. Now, let's go back to the scenario and what I would like, and as the patient has already said, even whether it's a young patient or old patient, they want to be spectacle free. That is the first thing. And they want it in both eyes, and they want it both in near, intermediate, and distance. Naturally, this is when you talk about spectacle free, you have to know that there are three distances which are very important. Near distance, it used to be, but nowadays with the advent of laptops and tabs and whatever you call them, the intermediate distance has come into very important, and this is what we have to look into. And so I will always ask at what distance the patient is. Either is a computer one, or he wants to do more near work, or is he reading a book, or whether he's using a laptop or anything. And then the other question which I will always ask him, what is his night habits? Whether he drives at night or not, and is he a professional driver, or he just drives once in or not. And what are his activities and hobbies? That is also very important, and we should know whether he wants a more intermediate vision or distant vision. If I have to operate on Saqib, who's sitting on left side of mine, so he likes to see aeroplanes. He works on aeroplanes. छोटे क्या कहते हैं उनको यार? Drones कह लो तो मतलब he wants a distance vision. मैं नज़दीक इसको ज़रूर